respiratory tract infection, and that is obvious. And that was, the Klebsiella species that was resistant to cefotaxime. Obviously, the next thing that is there is, as per the culture sensitivity report, we are supposed to change the antibiotic. That should be the third principle. Change specific drug on the basis of culture sensitivity report or the response, whether it is there or not. And hence, the patient was started on injection amikacin, 500 milligram twice a day, and it was given for a period of 7 days. Whatever antibiotics prior he has received has no value because the organisms has not responded to that particular. So we have to start with the day one and should continue treatment for 7 days. The patient was given the 7 days of treatment, and happily the patient became asymptomatic on within a week's time, and the patient went home after say 7 days. At the time of discharge in such type of cases, it should not be the patient is all right, cough has disappeared, everything is happy, patient is is ready now to give us a box of peda and then leaving. Should not be like this. What we are supposed to confirm that it is eradicated. Whatever organisms those are there are eradicated by repeat culture of appropriate sample and follow-up examination is required. So this is the classical scenario that we come across as far as this is a drug resistant case that is there. So what are the principles? Simple principles: decide whether the drugs antibiotics are required, whether it is moderate to severe illness that is there, start empiric antibiotics, which is prolonged spectrum antimicrobial agents, then administer most judiciously selected respiratory, urinary tract, skin, brain, meningeal, etc. So administer most judiciously selected drug based on host organisms and drugs, specific antimicrobial based on local resistance pattern. Try to identify, try and fight to try to. This, the microbiologists are going to play a heavy role as far as the success of the physicians in treating a case of infection. Let it be any, let it be bacterial, let it be viral, or let it be some sort of fungal infection that is there, right? They are supposed to, give us the report, and the physician obviously has to send the appropriate sample for that particular. So local resistance pattern, try to identify the causative organisms. Appropriate dose has to be given, appropriate for appropriate duration, I told you, and prefer rapidly acting, most effective antimicrobial agent for definitive therapy. Once the culture sensitivity, it should be a narrow spectrum antibiotic that should be, or the microbe targeted specific antibiotic that needs to be started in that case. So use of, then sometimes the combination of the drugs are required, right? Whenever treatment is prolonged, intensive treatment of highly error-prone organisms is required, and I told you to confirm the eradication. These are the basic principles of the antimicrobial. Let us see the second case. Keeping in mind whatever principles that we are supposed to follow. 24 years male. I'll not be going at the length discussion now. I'll be curtailing my discussion in short. 24 years male, admitted in April 2020. These are real cases with us. Patient came with the fever, thrombocytopenia, and renal failure. Once it is there, renal failure is there, thrombocytopenia, it is acute illness that is there, dengue is suspected, dengue shock syndrome is suspected, the might be BP is low, and the patient has received hemodialysis also for the whatever renal failure that was there. Obviously, it is modality of the treatment, hemodialysis, and the patient was put on left femoral HD catheter. And that was there almost for 6 weeks. The patient required dialysis frequently, and the HD catheter that was there for 6 weeks. And later on, once the patient became all right of the whatever dengue shock syndrome that was there, the catheter was removed. However, after 4 months of this particular thing, the patient started complaining to us of the persistent moderate grade fever. There was tachycardia, there was a breathlessness, and there was anemia. Now, to cut short the discussion, what next step that we are supposed to do? Now, the clinical scene is like this. Patient required hemodialysis. The patient had recovered from the, very severe, very bad critical illness, right? Recovered, but after 4 months, the thing that has happened. And that has happened because of what? Now, this is the story. 4 months. Catheter that was put, and the catheter, tachycardia, breathlessness, right? Catheter. And after that, the patient is coming to us. Here, straight away the patient was subjected for the 2D echocardiography, apart from so routine investigations, and right. And this 2D echocardiography is showing us there are large vegetations on the aortic wall. And obviously, large vegetations, those are there, should be there because of what? Should be there because of, not because of dengue. Dengue has subsided. Now it's there because of what? Catheter that is there. Organisms have passed from the catheter to the right side, and then to the, might be some shunt that is there, and then to the left side. the aortic valve is getting affected with the vegetation. When it is there, it is infective endocarditis, right? It is infective endocarditis. And when it is infective endocarditis, we should know that the patient are not going to recover for a period of, say, giving antibiotics for 2 days, 3 days, 1 week, or 3 weeks. A proper protocol is there for treating a case of infective endocarditis. Minimum 6 weeks of the antibiotics are required in this particular case. So that principle we are supposed to do. And obviously the blood culture has to be sent in this particular case. 3 samples. It should not be like this. One culture is sent, okay, infective endocarditis, sort of one culture is sent, and the thing is done. No, it cannot be like this. In infective endocarditis, when it is suspected, 3 cultures are mandatory. So we are supposed to send the 3 cultures, and 3 samples showed these particular organisms. Enterococcus faecium, that was isolated, and this was resistant. Oh my god, everything it is resistant. Linezolide, now it is linezolide that is sensitive. Then tigecycline is sensitive, and the thing is like this. The patient was started on linezolide, and the patient became absolutely all right. All symptoms started resolving within a period of 7 days, and everything got over after say 6 weeks of the complete treatment. So this is the another very bad scene that we can come across, right? Another scene, let us see. This is a 17 years female. There was a road traffic accident. The pelvic fracture that was there. Antibiotic resistance or antimicrobial agent resistance is not a problem. Will be in the MICU. Will be there in the SICU also. Will be there in the obstetric ICU also. Will be there in the ortho wards also. Everywhere the problem is going to be there. It cannot be pertaining to though I'm a medicine fellow talking more of a medicine cases. Let me take this particular case. The pelvic fracture that was there, right femoral neck fracture, and internal fixation was done. Here some procedure that was done. Internal fixation, implants in right femoral head, and then 3 months later, the implant is there. 3 months later, fever, groin pain, and swelling, restricted movement, and sinus. So now the infection has started there, right? Now here the basic principle has to be what? Whatever sinus that is there, whatever pus that is there, unless and until you drain it, you culture it, you find out the organisms, and you target those organisms, the patient is going to get. You have to remove all this particular whatever implant that is. Implant already is now infected. If you keep implant there and you continue antibiotics for n number of days, it is not going to be useful, right? So you have to remove this particular thing. So this is the thing. So implant was removed, the pus was cultured, and this was the pseudomonas that was grown. This is resistance. See the resistance everywhere. Resistant. It is sensitive only to polymyxin B and colistin. Polymyxin B, not so simple, not so cheap drug. These are very costly drugs for a prolonged period of time. Once you are here, and the thing is going to be really difficult, specifically at the RH level, or even with us, the things are becoming will be becoming to give this particular drugs for a prolonged period. It cannot be, given for 2 days, 3 days, and the matter is on. The patient is going DAMA, and the patient is becoming afebrile within a period of 2 to 3 days, and he wants to go. We cannot do it like this. We have to see that the organisms are completely eradicated. So a proper protocol, recommendations, those are there, has to be followed. The patient was started here on polymyxin B. Sorry, not polymyxin B, colistin, and the patient also became perfectly all right. So these are the so don't you think that these antimicrobial agents, let it be antibacterial, antiviral, antifungal, antiparasitic, or whatever these antimicrobial agents, those are there, are very powerful weapons? Yes, they are powerful weapons, no doubt about it, because they are going to save many lives. Otherwise, most of the patients would have died. Just think of the pre-antibiotic era. What you must have happened pre-antibiotic era, where the antibiotics were not discovered. The penicillin was the first one to discover in 1928. You just think of what would have been happening during 1901 or 1918, something like that. What would have been happening, right? The antibiotics are the savers, life savers. There is no doubt, antimicrobial agent. There is no doubt about it. This is how the antibiotics, those are discovered, 1928, 1932, and 2000 linezolide was introduced into the clinical practice. So the list is incomplete. Right, 2023. There are so many newer antibiotics that the antibiotics are discovered. However, as I told you in the beginning, only there's a battle always that is going on. All living organisms, they want to survive. Similarly, all these organisms, they want to survive. We want to survive. We are trying to kill them. They are trying to kill us. They are trying to kill us. And the battle will be going on. Battle is going on. Battle will be going on. There is no doubt about it. And throughout the history, there has been continuous battle between the human beings and multitude of microorganisms that cause infection and the disease. And the bugs, these bugs are smarter than human beings. They are just waiting for the antibiotic to come there at that site. and they are trying to be ready how I should defend this particular, how I should defend this particular thing. This is a weapon that has come against me, but then I should. So they are just waiting. So these bugs are very much for every new drug introduced, every new drug, there are resistance mechanisms in the bacteria waiting to it. Mind well. So how the first resistance that was reported for penicillin, FDA approval was in 1943. I'll just quote the examples. 1943, FDA approval was there, and first reported resistance that was there in 1940. Penicillin, now 2023. 1940 resistance. Nowadays we don't use it. That is quite obvious for many reasons. Not available. So many problems those are there. But then it tells you about the magnitude of resistance problem that can be there with the antibiotics. Or streptomycin 1947. इकडे भारत स्वतंत्र होतोय आणि तिकडे streptomycin ला anti-tubercular काय तर resistance develop होतंय. काय methicillin 1961, gentamicin 1969, vancomycin commonly prescribed nowadays, also we prescribe it quite often. Vancomycin 1987, the resistance that has already developed to this. Cefotaxime is 1981. Linezolide 9199. Those are 2000 ची पण वाट बघत नाही ते शेवटचा, right? Linezolide which was introduced 2000 ला ते म्हणजे मार्केट मध्ये आलं 1999 मध्ये. त्याचं ऑलरेडी इट वॉज फाउंड टू बी रेजिस्टंट, ऑर्गॅनिझम्स वर फाउंड टू बी रेजिस्टंट. म्हणजे असं होतंय, म्हणजे अँटीबायोटिक आज तुला त्याच्या आधीच कळलेलं असतं की the organisms are resistant for this particular thing. And this is how the timeline is going to be there as far as the resistance pattern is. Oh, forget about the old antibiotics, the penicillin, sulfonamides, and all those things. Recently introduced antibiotics, linezolide. Day and day out, we are using this particular linezolide, or say dalfopristin or daptomycin. Recently, you introduced tigecycline, dalbavancin, telavacin. Have you heard of these drugs? Have you heard these antibiotics? These are newer antibiotics, those are there. And mind well, a little amount of resistance already is there as far as these drugs are concerned. See, newer drugs are coming, new drug is coming, antibacterial resistance already is developing against all these organisms. पण मग प्रश्न असा आहे तो की किती अँटीबायोटिक्सचा शोध लावायचा, किती अँटीव्हायरलचा शोध लावायचा, रिसर्च किती लोकांचा करायचा, किती सबस्टन्सेसचा करायचा, हा प्रश्न. बरं, रिसर्च करायला ते काही साधी गोष्ट नाहीये. रिसर्च करणे म्हणजे त्याच्यासाठी फंडिंग लागतं, त्याच्यासाठी फार्मास्युटिकल कंपनी तयार व्हायला पाहिजे असते, राईट? इट इज नॉट दॅट सिम्पल टू आयडेंटिफाय. म्हणजे जो अवेलेबल ड्रग आहे त्याच्या विरुद्ध रेजिस्टन्स तयार करायचा आणि तयार झाल्यानंतर त्याला फेकून द्यायचा प्रयत्न करायचा, आणि मग नवीन ड्रग आला की त्याला म्हणायचं की आता त्या बग्स काय म्हणणार की नाही, आता आम्हाला यांच्या विरुद्ध ही रेजिस्टन्स तयार करायचं होणार आहे. दिस इज गोइंग टू हॅपन. टाइम इज गोइंग टू बी देअर when none of the antibiotics will be remaining sensitive for most of the time is going to come. So this is really a time to think on it, whether really and then मग त्यावेळेस पश्चातापाची वेळ येऊ शकते. अरे आपण कशाला व्हायरल इन्फेक्शनला ते सो मेनी अँटीबायोटिक्स आपण वापरले. एक दिवस एक टॅक्सिम देऊन पाहिलं, दुसऱ्या दिवशी काहीतरी काय अमॉक्सला देऊन पाहिलं. अरे काम करत नाही ना, मग 2 दिवस दिला, तर चौथ्या दिवशी आपण काय दिलं, लिनोझोलाइड देऊन बघूया. हे असले जे काही असं जर होत राहिलं तर आय डोंट थिंक द अँटीमायक्रोबियल रेजिस्टन्स इज नॉट टू अवे. That day is not too away from us. Remember this thing. So even for the newer antibiotics. So why divide upon resistance म्हणतोय antimicrobial resistance? What after all this antibiotics? This antibiotic resistance is defined as these microorganisms that are not inhibited by usually achievable systemic concentration of an antimicrobial agent with normal dosage schedule and or fall in the minimum inhibitory concentration range. Right? So I think Dr. Karikarte sir is going to elaborate more on this particular thing. But what is required for us, for clinicians? For clinicians, these organisms are required. Microorganisms are required. Unless and until microorganisms are there with us and a specific culture report is provided to us, we'll not be able to target that particular very for us, which is going to be very, very difficult to get. There is a term called as pseudo resistance, and this pseudo resistance should always be kept in mind. And this pseudo resistance problem is not identified quite frequently, and straightway the patient is labeled as resistance. But then before you label that the patient is resistant to a particular organism, think that it is a pseudo resistance that is there. And this could be because of, I will not be going into the details, time doesn't permit me. Inappropriate diagnosis, inappropriate drug is given, inappropriate regimen is given, certain local factor, foreign body infection आहे, ते जर काढलं नाही आपण antibiotics त्याच्यावर मारा करत राहिलो तर काय, what is the point? Resistance is going to be there. But then really removing this, the organisms will become sensitive. to that particular organism. So these local factors, multiplying forms, drug and drug interaction, food drug interactions, non-compliance, immunocompromised dose, like diabetes, first case that we saw, right? And anatomic abnormalities. All these should be thought of before you label. Is there an anatomic defect that is there? Is there, the non-compliance of the patient that is there? तर आपल्यावरनं विचार करावं, 5 दिवसाचा ड्रग घ्यायचं म्हटल्यानंतर आपण एक सकाळचा डोस घेतो. आय टेल यू 100% टाइम 5 दिवसाचं प्रिस्क्रिप्शन असेल ना, 5 दिवसापैकी निदान 3 डोसेस हे मिस केलेलेच असतात. इव्हन वी म्हणजे 3 तरी मिस केलेलेच असतात. हे इज दॅट करेक्ट दिस थिंग? दिस इज नॉट ॲट ऑल करेक्ट. म्हणजे माझ्यावरनं सांगतो ना, मी पण मिस करतो की कधी कधी, बट दॅट इज ट्रू. That is there, should not be there. Rather, let us learn from this thing. So drug resistance can occur to the bacteria, can also occur to the viruses, the fungi, endoparasites, or even to the cancer cells. There are certain terminologies. MDR means was resistance to 3 or more antibiotics. Extreme drug resistance, XDR, resistance to all but one or. What is pan drug resistance? PDR is resistant to all available, all available, or refer to pathogens that are specifically resistant to 7 antimicrobial agents. 7 मध्ये काय आलं? सेपिझिम, सेप्टाजिडिम, इमिपेनम, मेरोपेनम, पिप्रासिन, टाझोबॅक्टम, सिप्रोफ्लॉक्सिन, लिव्होफ्लॉक्सिन संपले. आपल्याकडचे संपले. याच्या पलीकडे कॉलिस्टिन, याच्या पलीकडचे पॉलिमॉक्स संपलं. कुठे तर जाऊ, फॉरगेट अबाउट द रुरल हॉस्पिटल. The colistin, how to give it, how much to give it, how long to give it is going to be a different problem. But then this really, when the resistance is developing to these many, there is an entity called as intermediate resistance. And what this intermediate resistance is, organisms can tolerate the normal antibiotic doses, right? They can tolerate, but are susceptible. They are resistant to normal doses, but they have become susceptible to higher concentration of the same antibiotics. Higher concentration दिल्यानंतर कधी कधी आपल्याला साइड इफेक्ट, ऍडव्हर्स इफेक्ट हे आपल्याला ते मग लोकांना समजून सांगणं. एक पॅच जरी आला स्किनचा, म्हणजे खाज जरी सुटायला लागली तर कसा प्रॉब्लेम येतो, कसं फेस करावं लागतं, तो ऑन ग्राउंड जो काही ट्रीटमेंट देणारा असतो त्यालाच माहिती असतं, म्हणजे कसं ते प्रॉब्लेम कसं सॉल्व्ह करायचं असतं. Right. How this? I think this. Let's come to certain pharmacological aspect of resistance. There are certain various mechanisms. Those are there. I won't be going again into the details. Inhibition of the first mechanism, common inhibition of the DNA RNA synthesis. So many drugs. Inhibition of the cell wall synthesis. Again, beta-lactam, glycopeptides, and so inhibition. The protein synthesis inhibition. Again, because of the lincosamides, macrolides, phenolics, etc., etc. Then destruction of the microbial membrane that can be there with the polymyxins, and then certain metabolic pathway abnormality that can be there, which makes the certain drugs resistant to the certain organism. The classical example that these are the certain examples where quinolones, rifamycin, and so on and so forth. Is that make sense? Okay, right. Cell wall synthesis or DNA, RNA. So these are the various the examples. Those are there. Beta-lactams, glycopeptides will be having different mechanism. Polymyxins and daptomycins will be having the disruption of the membrane integrity as a mechanism of the resistance. Aminoglycan is a classical, that will streptomycin or neomycin, gentamicin. Inhibition of the protein synthesis will be there responsible for sulfonamide trimethyl, is a classical, metabolic pathway abnormality that can give rise to this. So these are various mechanisms. Those are there. What is required for a drug to be really active in a particular individual? 3 important things. Those are required. One is the adequate transporters. When the drug is introduced, to act at one particular site, at that particular site, the transporters should be there, reaching at that particular. So the transporter should be proper, adequate in quantity, quality, and then there are the drugs that is going to be acting at either cell membrane, or she will be acting at the DNA level, at the RNA level, should be acting at the appropriate level, at appropriate site, and there should not be any efflux of the drug. Drug is that in that particular cell, and then there should not be a efflux of that particular, so to have maximum benefit. So unless and until all these mechanisms are thoroughly, properly, appropriately working, then and then the drug is going to be effective. When the drug is going to be, or the microorganism can attain resistance power just by breaking all these particular important things. Either transporter mechanism is going to get affected, or say target tissue that is there will be getting affected. Either efflux, maximum efflux is going to, so many ways are there, mechanisms those are there. for the resistance to develop in this particular case. And one more thing, the phenotypic resistance always is there. No, genotypic is phenotypic. Genotypic is also there. These are certain examples. Those are there. At what one certain mechanisms are complicated, means complex mechanisms where the drug resistance can be attained. At multiple sites, the resistance can be mechanisms can be responsible for the drug resistance. I think I need not go into the region. I'll just give one simple example. Aminoglycoside, those are there. Enzyme inactivation is the mechanism that is responsible for the drug. So there are so many other: decreased permeability, flux, all rest of this. See, 4 mechanisms are acting for the aminoglycosides to be becoming resistant up to a certain match. So not only single, but multiple mechanisms could be responsible for this particular. I tell you the H influenza, penicillin that was commonly used in H influenza. Beta-lactamase is an enzyme that is responsible for the resistance to develop in this particular case. Right, so there are so many mechanisms. The mutational mechanism, mutations are developing, and the selection pressure. One must know about the selection pressure. होतंय काय की n number of organisms those are there in a particular individual. We started with X name drug, whatever number of organisms those are there, by default 1 in 10 raised to 6 are the organisms. Those are naturally less susceptible in that particular colony to a particular antimicrobial. They survive despite the presence of antimicrobial agent, while the other strains are in. Certain strains they survive. Right? And these certain strains, they colonize further. They colonize. Getting me this thing? So X number of N number of organisms, out of that, certain amount of organisms are always going to be resistant. Right, rest of them are going to. So say, for example, make it simplified, 95% of the organisms are supposed to say susceptible or responding to a particular antibiotic, but rest of the 5%, they are trying to find, because they want to survive somehow. They want to have their nature with them, right? So these 5% of the organisms, they will now multiply, and if not taken care of, they will multiply with the other sensitive, the colonies, sensitive organisms, they will multiply there. So this is how the thing that will be happening, and what we call it as selection pressure. There are certain resistant genes also are there, right? Mutation that can be possible with various organisms. I think it's not practically very well. What is there as far as Staphylococcus aureus is concerned? It has become resistant to methicillin, oxacillin, clindamycin, vancomycin, linezolid. Enterococcus is concerned, already this is their Indian scenario. I'm telling you about the Indian scenario, right? Pneumococci, penicillin, cephalosporin, erythromycin, equinolones. What remains? Group A, streptococci, macrolides, ketolides, tetracycline, all everything. So this is Indian scenario. This is a proved thing that all the Vibrio cholerae, that is furosemide. Yeah, once upon a time it was very famous drug, furosemide, and that was taking care of within 2 doses, 3 doses, all cholerae, Vibrio cholerae, all used to get, patient used to get all right, but then not nowadays. Now they are not responding. Nalidixic acid, they are not responding. So many. So based on this current in that, not only this, but then the MDR, XDR, PDR, Indian healthcare system already is there. XDR is also there. PanDR is also there against the Staphylococcus aureus, Enterococci, aeruginosa, and streptophonems. So many superbugs. All these are now have become resistant to so many. Or forget about this thing. Recently, Acinetobacter must have been involved in that particular Acinetobacter. If you see so many Acinetobacters in our ICU, the number definitely has gone down recently, but it was quite, obvious something like say 1 year back or say 1.5 years back. We used to come across a lot many Acinetobacter, and you used to find, right? Imipenem, resistant, amikacin, resistance, epipene, resistance, and they are there, right? Thing that is there is, who are the individuals who get this particular drug resistance? That is the problem. Who are the individuals? Drug resistance. Drug resistance is more common who have recently used antibiotics. म्हणजे काय, आपल्याला 10 वेळा विचार करायला पाहिजे. व्हायरल इन्फेक्शन त्यांना फर्स्ट वेळा तरी अँटीबायोटिकला एक्सपोज करायचं की नाही, 10 वेळा विचार करा, राईट? अँटीबायोटिकला 1 वेळा एक्सपोज झाला की आय टोल्ड यू द सिलेक्शन प्रेशर. त्याच्यातले काही ऑर्गॅनिझम्स हे रेजिस्टंट असणार आहेत, and they are going to propagate, they are going to multiply in number, and resistant strains are going to come out, right? These colonies may exhibit phenomenon of cross resistance because of this particular thing. Cross resistance is possible from, similar mechanism or chemical class when it is antibiotics, those are there. Emergence of with this, what is going to happen? Once the resistance is developed, there will be untreatable pathogens will be there. Further selection pressure will increase, no doubt. One patient completely, resistant. Microbes are resistant, right? The colony selection pressure is going to go further, add more. So write this, and can occur in the family, can occur in the, anyone can be the sufferer for this particular thing, and it can spread in all over the. What is going to happen once there is antimicrobial resistance? There will be a compromised therapy of the human infections. There will be serious complications the patient will be developing, and that too when patient already has got some comorbid conditions like say diabetes is there, like say COPD is there already, right? Obviously, the length of stay, once the resistance means the stay is going to be more. Duration of the therapy is going to be further. So increase in the length of the stay is going to be there. Therapy is going to be prolonged. Prolonged hospital stay, increase in the number of treatment, cost is going to get increased. There are going to be therapeutic failures, and the relapses are also common. Again, the infection is not completely eradicated. Again, the relapses are going to be common. Mortality is going to be high. Costly and toxic agents we are supposed to use. So many adverse effects. So see the adverse things that are going to happen once the patient lands up into India. So it's a big problem, right? It is really a major threat to the public health. Basically, the question then that arises: who are responsible for the microorganisms to emerge, to persist, and spread of resistance? Who are responsible for this thing? I tell you, only 1% of the antibiotics are genotypically resistant to certain microbes are resistant to certain. Only 1%, and that is inherent by default. They are resistant because they cannot reach at that particular site of the. It's only 99%. I tell you, it is a phenotypic problem that is there. It is 99%, and this is the cascade that is there, responsible for the antibiotic resistance. One is the prescriber. Who is prescribing the drug? Prescriber related. Second one is the patient related problem. Third one is the drug related factors. Fourth one is the environmental factors. Fifth one is the pharmacist related problem. And sixth one is the pharmaceutical company related problem. All these, who left? Nobody's left. Patient is also there responsible for it. Prescriber is also responsible. Manufacturer is also responsible. The drug dispensing done by the pharmacist over the counter, they are responsible for it. Drug itself is responsible for it. Environmental factors are also responsible for it. And unless and until this chain is completely broken, antimicrobial resistance is going to persist, it's going to emerge, it is going to be persistent, it is going to be more and more. And a problem is that is going to be there is we are going to face, or we are going to come across an era of available so many antibiotics, but as if it is a pre-antibiotic area, as if it is pre-antibiotic era before 198, something like that, right? We are going to face this particular problem. What are these prescriber related? I'm going to concentrate only on prescriber and patient related. What are these prescriber related problems? Inappropriate and irrational use of available drugs. That is one. First. Second one is what? Inappropriate and irrational use of available drugs. Third one is what? Inappropriate and irrational use of available drugs. And fourth one is what? Inappropriate and irrational use of available drugs. By overuse of antimicrobials, inadequate dosing, inadequate duration, increase empiric polyantimicrobial therapy. You will be getting surprises in prescriptions. 4 antibiotics at a time prescribed on second day of the fever. 4 antibiotics. 4 antibiotics, cocktail of antibiotics. 1 aminoglycoside, 1 something like say other taxime or beta lactam. Such type of things are happening. And who is supposed to control this particular thing? These are the prescribers, and the education, learning by them is highly essential, to avoid this thing, inappropriate, inadequate duration, empiric, antimicrobial therapy, lack of knowledge and training, and that's why we are here. Everybody, all medical officers are at least something, at least whatever is being taught, it should really be taken into a teaching sense and should be applied at the ground level, should be applied at the, and so many new devices, those are, we don't know, so many new devices, those are coming, getting, infected, getting, once they are put, cannot be removed also. So things are happening like this. What about the patient-related problem? Patients, severity of the illness when it is there, diabetic patient, non-diabetic patient. Compare this thing. Diabetic patient will have a chance of getting more, resistant organisms, right? Like this. Immunocompromised state, poor adherence of the doses. I told you about in the way. Poor adherence of the doses. Poverty is there, self-medication is there, misconception about the antibiotics. म्हणजे एक आयुर्वेदिक आणि होमिओपॅथी वाले तर अगदी 100% विचार करा. I'm sorry for those medical officers who are, the Ayurvedic ones sitting there, but then they think antibiotic proper something went wrong. Am I audible there? Yes, speaker.
Yes, sir.
Yes, so, audible. Things are for patient-related problems. Those are there. There are certain, so many pharmacy-related or drug-related problems. Those are there. I'm not going to go into the details. Irrational fixed dose combinations are there available. Irrational fixed dose combinations are available, or excessive use of the detergents, excessive use of the cleaners or other antibacterials are also, hand wash that is there. Excessive use when it is there, microbes are getting, susceptibility is there, but then certain are going to, some, effect is going to be there. Certain microorganisms are going to get the resistance to this thing. So this is how the thing that is going to. The environmental factor, huge population in India, no question about it. Huge population, overcrowding is there. एका मध्ये तयार झाला की तो दुसऱ्या मध्ये फेकायला कधी पण तयार आहे. Like 1, 2, 3 multiple, plenty and everywhere. There is a market of all antimicrobial resistant cases. All these things are going to be there. Rapid spread by the transport facilities are so fantastic nowadays. One microorganism is going to another microorganism. So many problem that is there. How to prevent it? Prevention and treatment. Am I getting there? Yes.
Yes, sir.
How to prevent and treat this particular problem? Here the clinician has to play some role. Patient has to play some role. Pharmacist has to play some role. Pharmaceutical companies has to play some role. Institution has to play some role. And of course, the government authorities. Madam already has highlighted about the, the particular program that is going on since I think 2018. It is there. Sir already is there in that particular thing. Beautifully, it is going on. Should go on efficiently. That is what my concern suggestion is going to be there. Now, when you are a clinician, certain basic principles of antibiotic or antimicrobial agent prescription has to be followed. And if those are followed, I think the bulk of the resistance issue that will be coming up will be getting nullified. I tell you. Right? Say, for example, decide if really antibiotic that is required or not. Use it judiciously. Appropriate clinical specimen has to be sent for the culture and sensitivity. Perhaps before first dose of the empirical antimicrobial agent. Even a single dose is going to, and then a report can be there, there is no culture and sensitivity growth that is there, right? Rather, you should send the first dose culture before the first dose of the. Select the appropriate antibiotic based on the severity of the infection, pathogen that is identified, what is the geographical area, local resistance pattern, whether the patient has used previous antimicrobial agent or not, history of hospitalization that was there. One must know about the pharmacokinetics of the drugs. Pharmacokinetics and what is the site of the action that we are asking for that particular agent against that particular microbe. Think of pregnancy when it is there. Some issues are going to be there with the pregnancy, specifically safety and hypersensitivity. The cost of the drug should always be taken into account whenever, we have seen cases responding even to something like, say, simple amoxiclav rather than, say, piperacillin, tazobactam, something like that. The patient, they do respond. Rather, once it is identified that there is a culture sensitivity pattern that is a specific microbe, narrow spectrum antimicrobial agents. I told you broad spectrum only in mixed infections or when it is a severe infection that is there. De-escalation should not be forgotten at all. De-escalation. Very important thing. Once the culture sensitivity report is that is there, असं विचार करायचं नाही आम्ही 4 दिवस अँटीबायोटिक दिलेले आहे आणि आता कसं काय दुसरं चालू करू नाही. कल्चर सेन्सिटिव्हिटी सांगताय ना आपल्याला हात द्या तो द्यायचा आणि म्हणजे एखाद्या वेळेस असं होऊ शकतं की ऑलरेडी जे ड्रग चालू आहे त्याला सेन्सिटिव्हिटी पॅटर्न येऊ शकतो. अशा वेळेस तुम्ही जो काही हायेस्ट डोस दिलेला असतो एम्पेरिकली, दॅट ऑल्सो यू कॅन रिड्यूस, राईट? So the patients are definitely going to respond this particular thing. Well, if the patients are not responding after 72 hours of the antimicrobial agent therapy, then you are supposed to review your diagnosis. Thing has happened. Means the patient was started on antibiotics. Day 2, 3, antibiotics 72, day 5, infection not subsiding. What it is, then it's turning out to be really dengue. You revise your fifth day IgM report is coming. On fifth day, really the IgM report, dengue IgM report is coming. Fever, infection, antibiotic given for 5 days. Fifth day, dengue IgM positive. And then what it turns out to be, revise your diagnosis. So revise your diagnosis, and then really you can definitely stop in that case. So certain simple basic principles, and you are supposed to continue the treatment of the antimicrobial at least 48 hours beyond regression of the fever and other signs. Do not switch the antibiotic frequently or unnecessarily. Antiseptic precautions in the ICU, very, very important. And also in the hospital, infection control strategies has to be followed. Multi-drug regimens for the superbugs. Obviously, we are supposed to use multiple drugs in that case. Education of the patient, training is very, very important. Antibiotic policy, madam already has said about this particular thing. And vaccination of very, very important thing, simple important thing. As pneumococcal patient is there, has to be vaccinated against the pneumococcal vaccine. Why unnecessary? Ask the patient to land up into something like pneumococcal infection in the future, and then to treat it, to expose them to the antibiotic, and making the patient again to what? Resistant to that particular antibiotic. So vaccination policy is also going to be important. No antibiotics, please. No antimicrobial agents at all to a patient of strokes, seizures, overdose of any drug that is taken, acute head injury, trauma. पण मला वाटतं हे शिकवायला आणि सांगायला बरं वाटतं, पण काय प्रॅक्टिकली हे होत नाही. प्रॅक्टिकली काय होतं की हेड इंजुरीचा पेशंट आला की काय, वन द पेशंट इज टू बी सेपोटॅक्सिन और प्रेसिंटाइजोबॅक्टम इज टू बी, असं एक प्रॅक्टिस, ही अशी एक ऍटिट्यूड, अशी मेंटॅलिटी तयार झालेली आहे, विच रिअली, हा, इफ इट इज रिअली इन्फेक्शन दॅट इज देअर, वी ऑलवेज शुड बी स्टार्टिंग, शुड नॉट डिले इन दॅट केस ऑल्सो. बट दे अननेसेसरी इन अ पेशंट ऑफ हिमरेजिक शॉक, इन अ पेशंट ऑफ पोस्ट बीटीसीए, से कार्डियक पल्मनरी इडिमा आहे. कार्डियक पल्मनरी काय क्रेप्स तर आहेत, रेस्पिरेटरी इन्फेक्शन मध्ये पण लागतात, इथे पण लागतात. मग काय क्रेप्स आहेत म्हणून अँटीबायोटिक द्यायचे का? अरे कार्डियोजेनिक पल्मनरी इडिमा आहे तर काय त्याला लॅसिक्स द्या, ते डिकंजेशन करा, and the patient is going to be absolutely okay within a period of next 8 to 10 to 12 hours like this. So remember all this. Phage therapy is in practice nowadays. Bacteriophages, I'm not going to go into the details of this thing. This is going to be a little costly affair. But then as far as the patients are concerned, what strategy that they can adopt is self-prescription. मला सांगा तुम्ही, एक 5 ते 10% लोक असे असतात की ताप आला ते ओव्हर द काउंटर जाणार, त्यांना सांगणार मला क्रोसिनची गोळी द्या, किंवा ते सांगणार त्यांना मला एझिथ्रोमायसिनचे. अरे कोविड नंतर ते एझिथ्रोमायसिन काय आणि टॅक्सिम काय आणि ते ड्रग्ज असे काही लोकांचे पाठ झालेले आहेत आजकाल तरी, की ते म्हणजे ते डोंट गो टू दी ट्रीटिंग फिजिशियन और डॉक्टर, ते ओव्हर दी काउंटर. आणि तेवढाच रोल मग ते फार्मासिस्ट आलेत ना, आपल्याला काय आपले 10 गोळ्यांची टॅबलेट जाते ना आपल्याकडनं, आपल्याला पैसे मिळतात ना, म्हणून त्यांनी सांगितलं. किंवा ते पेशंट लोक विचारतात त्यांना, तुम्ही आता मला कधी सर्दी खोकला झालेला आहे, तुमच्याकडनं काहीतरी अँटीबायोटिक द्या, असाच प्रश्न टाकला जातो. आणि अँटीबायोटिक द्या असं फार्मासिस्टला जेव्हा प्रश्न टाकला जातो, तो काही म्हणणार नाही की नाही तुम्हाला गोळीची गरज नाही, तुम्हाला एकाच दिवसाचा टॅबलेटची, एकाच दिवसाचा फीवर आहे, 2 दिवसाचा फीवर आहे, हा काय अँटीबायोटिक पाहिजे ना, मग तुम्ही अँटीबायोटिकच्या जोडीला तुम्ही अँटीसिड पण घ्या, आणि तुम्ही लागल्यास कफ सिरप पण देतो मी तुम्हाला. आणि तुम्हाला काय असतं, त्यांना ते एक्सपर्ट म्हणजे हाफ एक्सपर्ट असतात ते, त्यांच्यामध्ये ते म्हणतात की तुम्ही ॲलिग्रा पण घेऊन टाका ना. मग असं कशाला, म्हणजे हे असं हे ते सुरू होतं. आणि मग ब्रेक कुठे करायचं, when the patient himself, when the prescriber himself, when the pharmacy himself, फार्मास्युटिकल कंपनीचं तर आणखीच वेगळं गणित असतं त्यांना. I think that issue I'm not going to take it out. But then these are the things, there are certain infections where should not be a concept of the prophylactic antibiotics. yes, barring certain exceptions. Say, for example, in a patient who has got infective endocarditis, it is a well-known scientifically proved thing that in infective endocarditis, you are supposed to give the prophylactic antibiotics, either ampicillin or clindamycin. So recurrent cellulitis associated with the lymphatic obstruction, we are supposed to give the prophylactic antibiotic. Recurrent cystitis in there in women, we are supposed to give. So, barring certain exceptions, I think the prophylactic antibiotics. As far as the pharmacy is concerned, they are not supposed to prescribe the drugs without doctor's prescription. This should be, I think, made a law for this particular thing. And unless, right, don't is there, but then is not, scrupulously followed. Don't advise antibiotics over the counter. Patient education, all these things are important. Institutional level. I think Madam has already discussed so much of the program that is going on. The antibiogram, hospital antibiotics, you are going to cover it. So I am not going to tell into the antibiotic surveillance. Madam has already told you. And मग काय हे सगळे न्यूरो अँटीबायोटिक्स जात आहेत, त्यांच्या विरुद्ध रेजिस्टन्स तयार होतोय. मग उरला प्रश्न एक आपल्याकडे नवीन अँटीबायोटिक तयार करा. नवीन अँटीबायोटिक तयार करायला फार्मास्युटिकल कंपनी तयार व्हायला पाहिजे. फार्मास्युटिकल कंपनीला पैसे लागणार आहेत, खूप भरपूर पैसे लागणार आहेत. आणि जोपर्यंत पैसे मिळत नाही, जोपर्यंत तो इंटरेस्ट आहे पैसे मिळण्याचा, तोपर्यंतच ते फार्मास्युटिकल कंपनी पण काम करणार आहे. ते काय असं म्हणणार नाही मी फुकटमध्ये हे तुम्हाला शोधून देतो किंवा याचा आपण शोध लावूया. हे असं होत नाही. त्यांचाही त्यांच्यामध्ये काय फायनान्शियल इंटरेस्ट असतो. आणि बघा हे, इफ यू सी इट, दी अँटीबॅक्टेरियल अप्रुव्हल सिन्स 1983, past 25 years, only 15 antibiotics of 167 under development had a new mechanism of action. न्यू मेकॅनिझम ऑफ ऍक्शन. असं काही फायदा नाही ना, जुने मेकॅनिझम तेच अँटीबायोटिक तशाच मेकॅनिझमचं काय, देर शुड नॉट बी एनी the issue is not going to benefit us. So incentives जोपर्यंत कंपनी. So dear friends, a big problem that is there of this thing, antimicrobial resistance, no action today. We are going to come across this particular antibiotic era. We are going to face this particular problem. And if really it is there, resistance, when it is there, resistance already is there. There are going to be, patients are going to, they are coming to me also. What are we supposed to change the drug according to the culture sensitivity report? Combination of the antimicrobial with the synergistic action that we are supposed to use. Bactericidal drugs. When it is antimicrobial resistance that is identified, bactericidal rather than say bacteriostatic drugs, we are supposed to specifically for the meningeal infections, the bacterial endocarditis, and immunocompromised hosts. And then the beta-lactamase when the patients are using, say, beta-lactam antibiotics. Simple, verapamil. The research already has shown the verapamil, verapamil, antiarrhythmic drug or antihypertensive drug, that when it is used in a patient of falciparum malaria, the efflux of the drug, others say whatever drug that is less. So if you know this particular thing, the resistance will not be getting against the, say, malaria. This is just a slide that I'm trying to show, but these are the organisms where already what we used to use. But what are the alternative drugs? Those are there. Specifically, say for example, staphylococcus, cloxacillin was there, but nowadays vancomycin linezolid resistance may not be that to that extent it has developed. So cloxacillin, when it is resistant, we can use vancomycin. This is just one example. It is there, and other adjunctive measures can always be practiced to prevent the antimicrobial resistance. Vaccination. In certain selected cases, steroids, definitely they are going to be useful. Drainage of the pus, the amputation when it is a gangrenous limb that is there, and the removal of the catheter when it should not be kept for prolonged period of time. I think that is again a big source that can be there for persistence of the infection and the development of the. Here really, that's why we are sitting together. Microbiology HOD is sitting, I am delivering my talk, you all fellows are there, medical officers are there. Really, there should be a big balance that should be there as far as the AMAs are concerned. Microbiologists are also of utmost importance there. They are the pillars, they are the important one to provide, obviously the physicians are supposed to send the sample, appropriate sample to them, then and then the what culture and sensitivity pattern that is. And obviously the pharmacologist with us are the pharmacologists. They should be, ready to make the appropriate drug available. म्हणजे यांनी सांगितलं आम्हाला की हा ऑर्गॅनिझम आहे, ही सेन्सिटिव्ह पॅटर्न आहे. आम्ही विचार केला की हा ड्रग चालू करायचा, की आता लिनेझोलाइड चालू करायचं आहे, कॉलिस्टिन चालू करायचं आहे. तर फार्माकोलॉजिस्ट शुड ऑल्सो बी coming into the picture, they should make it available as far as this. So when all these pharmacologists, microbiologists, as far as the treatment of MDR is concerned, I think, friends, with this particular whatever teasers, brain teasers in the beginning, I showed you what do you mean by antibiotic resistance and so on and so forth, right? So I think these questions must be very clear to you. I'll be stopping myself after providing this particular case. Just again at the end of brain teaser is going to be there. What can this be the case of? Just in next 2 minutes only. 14 years male, admitted with high grade fever with chills, exertional breathlessness and joint pains. That is there for 10 days. History of anorexia is there. No history of rash, bleeding, nothing is there. No other things. I think it has come. Okay, past history. He was operated in 2011 for ASD closure. Treatment history was evaluated and treated outside for 4 days with working diagnosis of infective endocarditis. ASD आहे, infection आहे, 10 दिवसापासून चालू आहे, already some heart disease that is there. So infective endocarditis will come in thought already. So infective endocarditis was thought and the patient has received antibiotics. What antibiotics received, we don't, right? And then personal history wise, the sleep was less and the appetite was also reduced. Family history was not found. At the time of entry to us, the patient was febrile, the AMI was 13, the patient was hyperkinetic, BP was 100/60. There was a pallor, there was a grade 1 clubbing, and the peripheral signs of infective endocarditis were there. Infective endocarditis peripheral signs were there. TVS examination revealed something like, say, grade 3 pansystolic murmur leading to axilla, mild hepatomegaly, moderate splenomegaly, and so on and so forth. And outside investigations, there were vegetations on 2D echocardiogram. 2D echography vegetation of 2 to 3 millimeter size on anterior mitral leaflet. Blood culture was 3 samples. Blood culture was sent. 3 samples were sent. There was no growth. And ASO titer was positive, almost 1 in 216. CRP was positive, ESR was 26. So by and large, so far we are dealing with a case of infective endocarditis, and the patient already has received some antibiotics outside, and the blood cultures obviously are negative. So they are going to be negative. Might be the drug sensitive organisms could be there. Proper drug patient might have received, but then still the patient there is no response. The patient is coming to us with the fever and so on and so forth. RBCs indices are suggestive of iron deficiency anemia, mild proteinuria, and E. coli and Klebsiella were there in the urine on once. Otherwise, subsequent urine reports were normal, and subsequently repeat your routine examination and clinical course was fairly normal. The patient has received some sort of antibiotics for a period of a few days. Blood culture repeated 4 times. Blood culture, as per the Duke's criteria of the infective endocarditis and all. They detect no fungal. Urine culture was negative. Patient is running fever and fever and fever. Some sort of ASD that is there. Fever is there. Hepatosplenomegaly is there. Some iron deficiency anemia is there. Patient is not responding. Some sort of 2D echo. First 2D echo was showing infective endocarditis vegetation, and when it was repeated on 10th October, it was there were no vegetations. There are no antibiotics the patient is receiving. There are no vegetation. Might be the antibiotic. We don't know whether the first report was correct or second report was correct. But the very fact that was there, the patient is with us and the patient is not responding. Patient is running fever and fever and fever and fever and fever. Lot many antibiotics. And I tell you, hepatosplenomegaly that is there is still persistent. Kidney, some liver problem is appearing now. Some kidney problem is appearing. Everything is appearing now. So many. I tell you, the list of antibiotics. List of they would have been projected there, no? List of the number of antibiotics he has received. Ceftriaxone for 21 days, gentamicin for 28 days, doxy for 14 days, artesunate for 5 days, azi for 5 days, metro for 7 days, vancomycin for 21 days, benzathine penicillin, single dose on say 22nd October. I don't know why it was benzathine penicillin. IV ceftriaxone that was given for 7 days, and IV meropenem was given for 7 days. Oh my, which is the antibiotic that's left? Culture reports are turning out to be negative. Hepatosplenomegaly persistent, fever persistent, so many antibiotics, right? What is this happening? Vegetation, those were there, are now not there in the 2D echocardiography. The rest of the blood parameters are not showing that it is some, the ongoing, persistent infection that to my extent, again the patient has restarted. Ceftriaxone was restarted, and then amikacin was started, clindamycin, linezolid was started. So what antibiotics is still there now? So what is this? What is this? What is this? What? She rightly saying it was a drug fever. It was antibiotic fever that was there. And I tell you, all antibiotics were stopped. The patient was admitted in our CVTS site for infective endocarditis, CVTS site. All antibiotics were stopped. And to our, why it should be a surprise? On very third day, everything started declining. Fever subsiding, hepatosplenomegaly is going down, the appetite, the well-being, everything is getting improved. This is the antibiotic. These many antibiotics, the problem that can arise. So it was like, drug fever that was there. So proper diagnosis is also essential whenever you want to consider. Otherwise, I don't think that this patient will be sensitive to a particular organism. Not only this time, there is no question of persistent problem of infection here, but in future also is not going to be sensitive for most of the organ. Who is responsible for this? Who is responsible for this? Patient is responsible? No, patient is never responsible. I won't say further sentence. Thank you so much.
Sir, thank you for wonderful session, especially case presentations and culture sensitivity importance in diagnosis. So it was wonderful. Many of us were not aware about this issue, which is very multidimensional. But sir has explained very critically about all multidimensional issues. So thank you very much, sir, for this.
Thank you.
I'm welcoming next speaker, our Dr. Rajesh Karyakarte, sir, for taking next session. Sir has already completed MD in 1988, so he has almost 33 years experience in teaching. Sir has contributed many national and international conferences and many research papers in journals, various journals. He was a member of COVID task force as well. Sir, I'm not taking much time to introduce you, but
Thank you very much. I would start because after such a marathon session by sir and also everything by Dr. Jyoti Bajaj, I think my job now remains is to summarize the whole thing fast. I think last 5 hours are remaining. I would hit as many sixes as I can. So let us move further. AMR surveillance and genome sequencing. I would be dealing with genome sequencing at the last, but I would like to just cover and summarize the whole thing which was covered up till now. So we'll start with it. Antimicrobials, you have antibiotics, antivirals, antifungals, and antiparasitics. These all together make our term antimicrobials. The important thing is about the narrow versus broad spectrum. I think sir has made it very clear of how you have to use a narrow spectrum over a broad spectrum antibiotic, because if you use narrow spectrum antibiotics, there is a chance of lower resistance development as compared to broad spectrum. If you use broad spectrum antibiotics, there are more chances of developing drug resistance. So it's always preferable to use narrow spectrum antibiotics whenever possible. Then coming on to what is antimicrobial resistance, I had made mention about the mutations. Yeah. So antimicrobial resistance occurs when bacteria, parasites, viruses, or fungi change to protect themselves from effects of antimicrobial drugs designed to destroy them. This means that previously effective antimicrobial drugs used to treat and prevent infections may no longer work. Then the importance of AMR. AMR is so important that WHO says that is one of the biggest threat to global health. Then now what is the problem? I think sir had and even Jyoti very clearly told us what is the problem. Just think of the scenario tomorrow, because today we are able to do so many surgeries. We can replace a hip, we can replace heart, we can do almost any type. We can do transplantation. There are so many surgeries which we do. Now all these are possible because of antibiotics, because antibiotics reduce post-operative infection rate below 2%. And without these, there would be a 40 to 50% rise in this, and 30% patients would die from resistant bacterial infections. So mortality would be very high after even simple procedures if we let this problem of antimicrobial resistance increase in the world right now. So here I would like to take you to this particular figure, where right now AMR is at a lower level, but by 2050, if this goes on and we don't have a break somewhere, It's going to be the highest killer in the world in all the diseases. Now, this is one more thing which I want to emphasize to everybody. That particular point is antibiotics are very useful to the patient who takes it and he gets all right. So it's a magic drug for him. But if it's done in a wrong way, as sir has already told us, the problem is when it develops resistance, it is a big problem to other patients and the society at large. So it's a unique medicine. It's very good. It's a magic thing for a patient who gets treated. But when drug resistance develop, other people and the society is going to face the brunt. Resistance is increasing. Why is it increasing? It is very clear to us now. By the end of this particular workshop, we know that it's the misuse and overuse of antimicrobials in humans, animals, and plants, which has led to all these problems. These are just the examples of how drug resistance spreads from the patient to the hospital, to the workers there, and to the other patients. Similarly, from animals, it can go through the fertilizer and water, infecting new people. So, One Health concept is very important here, where drug resistance is not just the problem of prescribing physicians as we think it is. It is also because there is a lot of antimicrobials which are used in poultries, in cattle rearing, in fisheries, almost everywhere, even in plants. We use antimicrobials, and this has led to a big issue. And therefore, everything has to be taken together. And therefore, antimicrobial resistance is a part of One Health project. It was long back when Sir Alexander Fleming got a Nobel Prize. He got a Nobel Prize for discovering penicillin. But he made a very important statement when he was receiving the Nobel Prize, and that was a thoughtless person playing with penicillin treatment is morally responsible for the death of man who succumbs to infection with penicillin resistant organism. So this every physician should remember. If he's going to misuse the antibiotics and is going to lead to resistance, every person who is going to die because of that resistant bug, the whole thing is on your head. So we have to be very careful when we are treating people with antimicrobials. Okay, so what happens if antimicrobial resistance is there? There's treatment failure, there is reinfection, longer stay in hospital, longer recovery times, higher risk of mortality, and significant financial cost. Now, this is a very, very important thing, significant financial cost. You just try to understand that you just give a simple Septran costing some few rupees and then turning out to these costly drugs where a single dose is going to cost you hundreds of rupees. So this is what we have ultimately made, that all the cheaper antibiotics are nowhere to be seen. It's just the costlier antibiotics, which is making treatment very difficult. Antimicrobial stewardship was covered. I will just say that everything has to be right so that for example, right antimicrobial, right patient, right time, right dose, right route, right duration, and right documentation. This is what antimicrobial stewardship is. You need to have a team in your hospital. So all PHCs, if you have these many people with you, you are lucky, of course. So, but then you need a microbiologist, an infectious disease specialist, and antimicrobial stewardship, pharmacist, and all these people, nurses. So wherever in your place, you can make a team which would see that the antibiotics are prescribed properly. What can public do? What can people do at home? Not to take antibiotics without prescription and discard old antibiotics. And in industry has to invest in research and development. And as Borses sir said, unless there is some financial gain, nobody is going to invest in making new antimicrobials. We know of the problem of COVID-19. Nothing has to be emphasized. Everybody took antibiotics just because he had to take antibiotics. And still now those people, every people in India has come to know the names of antibiotics. Therefore, it's misused to a very large extent right now. Yeah. So the key message is organisms evolve and develop resistance, and effective antimicrobials are reduced in number, and everything is happening now. We have a pandemic going on at present of antimicrobial resistance. There's the same thing. So this is just to tell that you have to use antimicrobials very judiciously. This particular thing tells you that antimicrobial resistance is a big problem, and it's a problem of One Health rather than only patients and the doctors. Yeah. So this was touched up by Dr. Bajaj, so I won't be dealing much in it. WHO is committed. It committed in 2015, and it told that each member state should have a national action plan on AMR. So from May 2017, we have it. I was also told that I would be talking on surveillance of antimicrobial resistance, and therefore the most important uh, method is Global Antimicrobial Resistance Surveillance System. This is acronymed as GLASS. So it is GLASS which we have to understand. GLASS is totally based on phenotypic resistance, and there in each microbiology lab, we have something called as a minimum inhibitory concentration test. This is the gold standard, but the most commonly used test is the disk diffusion testing, and this is the commonest method which we use. And this is the reports which are generated from this particular methods are ultimately collated by this particular GLASS, which was developed by WHO. So this is how it is. It was touched by Dr. Bajaj, and that was phenotypic resistance is delayed. The physician, Dr. Borse sir, also said that it takes 48 hours, so it is slow, and so that is the reason why empiric treatment has to be started. Otherwise, there wouldn't have been anything called as empirical treatment. Empirical treatment is basically started because you don't get the exact reports in 48 hours. So that is a problem which we have to solve if we want to have a proper antibiotic treatment. So to overcome this, what WHO has suggested is that we can depend on molecular diagnosis of AMR to report it faster. So what we have is, how do you detect that? You detect that by detecting resistant coding genes to see for mutations, and this can be done on DNA, which is extracted from purified bacterial isolates. So if you want to grow bacteria, that is going to take 24 hours, and then you can test for mutations, or you can directly test it from clinical samples. If you do it from clinical samples, it is going to be much faster, and it is going to be very advantageous to the patient if we are able to give reports as fast as possible. So what do we do in molecular testing? Just to give a very easy example, Staphylococcus aureus, for example, MRSA, that is methicillin-resistant Staphylococcus aureus, we can confirm it very easily by showing two genes, MEC-A and MEC-C. If we show this with the DNA molecular methods, we can say that you don't use this particular antibiotics at all. Or, for example, in E. coli and Klebsiella pneumoniae, we can find for genes which would show ESBLs in the patient, and therefore these cannot be then used. Even carbapenemase gene can be detected, and if it is detected, this particular antibiotic should not be used for treatment of Enterobacteriaceae family. Yeah, so what does GLASS do? It studies these organisms. There are 1, 2, 3, 4, 5, 6, 7, 8 organisms which are tested, and these antibiotics which are there. It goes on doing surveillance for this, and then comes up with policies which are given to the clinicians so that they can avoid certain antibiotics in when they suspect certain organisms, because these organisms cause infection which are common in a particular site. For example, urinary tract infection, you are going to get E. coli, and if it is E. coli, you can avoid giving certain antibiotics, to which GLASS tells you that resistance has already developed. Then what is our national commitment? Our national commitment is that we have a national health policy. In a health policy, we have already defined that AMR is one of the top 10 priorities of Ministry of Health and Family Welfare. So we have a plan. This is the global plan. Please try to see these things. I already told by almost all speakers: awareness and understanding, surveillance and research, reduce infection, optimize the use of antimicrobials, and increase investments. This is the National Action Plan on antimicrobial resistance. So the first one was launched by NCDC. It was in the 12th 5-year plan. It was from 2012 to 2017. And its plan is to involve 30 network laboratories in it. There's one more network in India, which is run by ICMR labs. There are 15 labs, 15 medical colleges are involved. So in all, there are 45 medical colleges and labs which are involved in surveillance activity against for antimicrobial resistance. To begin with, there were 10 laboratories, and I'm proud to say that BJGMC Pune was one of those from the beginning of this particular surveillance activity. Only 4 pathogens were seen at that time. Later on, Pseudomonas and Acinetobacter was added. The most important thing which came out from that particular early thing was there is very high resistance to fluoroclonazone, third generation cephalosporins and carbapenems. And the resistance to reserve drug, luckily, Dr. Borse sir, luckily for you, vancomycin and colistin still work. So that is how the things are. Then we have to strengthen laboratories and surveillance of antimicrobial resistance. These are the priorities of National Action Plan of Antimicrobial. It's also called as NAP AMR. I'm dealing only with this one, strengthening knowledge through surveillance. So these are the strategic priorities. This is what we have to do. So for human health, it is NCDC and ICMR. For animal health, it is ICAR and others. And India is already enrolled with GLASS. Then moving further, all these standards. So if you see humans, animals, food, and environment has to be taken care of if we want. So there's an One Health approach which has to be taken into consideration when we are going to deal with antimicrobial resistance. So right now, what we have surveillance for these 9 organisms: Enterococcus, Staphylococcus, Escherichia coli, Klebsiella, Acinetobacter, Pseudomonas, Salmonella, Shigella, and Vibrio. I'm very sure that all of you remember these names from your second MBBS. Then these are the samples which are to be dealt with: blood, urine, pus, and other sterile body fluids and stool. So this is how we do AMR surveillance. The clinical specimen is blood, and these are the priority pathogens. Urine has its own pathogens, then pus, other sterile body fluids, and lastly stool. So this is how AMR surveillance is done. These are the priority pathogens. I will be moving very fast because I know I have to. So these are the priority pathogens, and these are the tests. These are the labs which do this surveillance in India. Now coming into the last thing, that is the genome sequencing. This is a very important topic which I'm going to discuss, and this is going to be the future of AMR surveillance. It's called as wastewater surveillance. Now here we have to understand that all the national programs or all international agencies right now, they are focusing on few pathogens in the clinical settings. So what is happening is large number of patients are there. We are doing all the surveillance in hospitals in these patients. So all our studies are biased. They are biased only with people who have clinical signs and symptoms and who have landed in a hospital. We never know about the antibiotic resistance which is there in the commensal microbiota, which is there in healthy individuals, because this is very important as there is a horizontal transfer of resistance. So your normal organisms, which are commensals in nature, have drug resistance with them. They can transfer this to the pathogenic bacteria, and that we are not seeing at all. So AMR in total population is an unknown entity to us. Right now, the entire surveillance activity is in hospitals, and therefore we know only of the drug resistance in pathogens. We don't know about the drug resistance in other organisms. So how can we avoid that? What can we do? We can do it with the help of wastewater surveillance. And how is it done? It is done by testing for antimicrobial resistance genes in municipal sewage. It's a very cost-effective way because you are looking at a very large population. Almost the entire city population can be dealt with if you are going to use this particular sample from municipal sewage, where we can go in and detect the respective genes inside that particular samples. So what are we looking at? We are looking at all the entire bacterial biomass in that particular city, the pathogens, the commensals, everything. And in addition, it would also include those organisms which you are not going to find in any case, because you would find the symptomatics. But here, even the asymptomatics, pre-symptomatics, post-symptomatics, all the samples would be there with you. The samples like feces, urine, nasal mucus, skin, sputum, everything goes in your sewage. And from there, we can see whether there are pathogens there or not. We can see whether drug resistance is there or not. So this is the thing which is the future, which is being tried at in many countries. India is also doing it at present. So yeah, what are we doing here? We can identify the resistance genes by the help of PCR methods. They are PCR-based methods, and the most important now is the genome sequencing. What we can do there is by the genome sequences which we have right now. There are four generation genome sequences. What we can do is we can detect all the resistance gene in that particular sample, and this can tell us what are the problems. It can even identify the gene. From the gene, it can identify the organism, and therefore we can have a very good database where we know what genes, resistance genes are present in an organism, like for example, Staphylococcus, Escherichia coli, Klebsiella, and this would be the real resistance problem, and it can make antibiotic choosing a very easy way for the clinicians. So thank you very much. With this, I end. Thanks.
So thank you very much for delivering the wonderful session regarding surveillance activities and about genome sequencing as well. Sir, there is one question in chat box. Right? Can antibiotic affect the vaccine-induced immunity given at the same time? So any of you can just answer for this.
Nice.
Hello, sir.
But the organisms. See, antibiotics would be acting against bacteria. So bacterial vaccines, if you're going to take a bacterial vaccine, then there would be a problem. Now, for example, you are taking a COVID vaccine. A bacterium cannot act against a virus, and therefore it is not going to affect the efficacy of vaccine in such situation. If you are going to try a vaccine, meningococcal vaccine, and you are giving antibiotics which kill meningococca, and if you never go in for a live vaccine. No, generally we don't go for a live vaccine. So live polio virus was there, but polio virus cannot be affected by antimicrobials. So I think we'll have to define that question. We'll have to frame that question very specifically to get a specific answer. Otherwise, both the things are not related at all. Thank you.
So there are more questions, sir. Does the resistance in fungi and virus runs on the same lines like the bacteria?
Yes, it does, because the whole resistance thing is based on your genes. And therefore, if there is a mutation in the gene, the things are affected. For example, the simple thing is if you have an antiviral which is getting attached to a particular protein on the surface of a virus, and that particular protein is mutated, so the shape of that particular protein on the surface of the virus would change, and that particular drug would just not get attached to it. If it's not attached to it, it's not going to act on it. Particularly, drugs in the forms of monoclonal antibodies are evaded by viruses in this particular form. This is the main reason why you had the variants in COVID. These antibodies. It was to evade these monoclonals, that these organisms had changes in their genome. That was the thing. Yeah.
So next question is, how pharmacist is responsible for drug resistance, which is already mentioned by Dr. Borse, sir.
No, the I would answer it. The pharmacist has to abide by the law of the country. The law of the country says that only if the physician advises a particular antibiotic, only then it has to be given to that particular person. If he gives it without a prescription, he is not following the law of this land.
The appropriate antibiotics will not be given by the pharmacist, even if the patient is asking for it.
Yes. Sir, which is the most dangerous resistance, fungi, virus, and bacteria out of these three?
आपण म्हणजे कळायला लागलं ना क्विज कॉम्पिटिशन करतोय की काय any bacterium, any pathogen which can kill a person, if it becomes multi-drug resistance, it is the most dangerous thing to happen to you. That is the answer for this. For example, just take an example of if a fungus is said Candida auris, this particular organism kills a lot. Tuberculosis, this organism, if it is multi-drug resistant, is going to destroy you. So that is how it is. But then it depends because these are all pathogens. They can kill. And if they become drug, for example, Shigella became drug resistant. Salmonella would have been treated very easily by drugs. But now you know that Salmonella has taken drug resistance from the normal flora, which I was talking of, the horizontal spread of resistance from other bacteria like E. coli, Klebsiella. They gave their resistant genes to Salmonella, and Salmonella became drug resistant. So that
Single organism cannot be pinpointed. That it is most dangerous. Yeah, single organism cannot.
Yes. So next question is how environment is responsible for drug resistance?
So sanitation problem is going to be there. Overcrowding is going to be there. One single strain persists is there in the community or in that particular area, right? Will be obviously the spreading is going to be there to others.
See, we are using a lot of antimicrobials to make the chicken fat so that we can earn more money. We are giving antibiotics to the cattle so that they give more of milk. Now, in this situation, if these antibiotics are given, all the organisms in their gut are going to get resistant. They are going to defecate on the soil. The environment is going to get affected. This particular feces would ultimately reach water bodies. From there, you're going to get infected. It's going to be there on your crop. It is going to be everywhere. So this drug resistance spreads from environment in this particular fashion. Even in fishes, the fishes are getting this particular dose of antimicrobials. Every place you're going to get antimicrobials, and therefore that is the reason environment is very important.
Sir, may I add something? Sorry, I had just.
Yeah. How, Maidan mein
Yes, yes. So these ARGs, antibiotic resistant genes are, in fact, the next big target is going to be the environment, which is the common source, as Sir has already mentioned, where these resistant genes will be transmitted from human to environment, environment to animal, again, environment to fishes. And another big thing that is going to come up is the integrated surveillance, where we will be able to actually document this transfer of genes from humans to environment and vice versa. So yes, that's a very important source that can lead to more resistance. Yeah. And it's huge, not manageable.
Thank you, ma'am. Thank you, ma'am. So next question is when is the best time to order test like blood test before starting patient on antibiotics? So I think Borsis sir can answer on this problem.
It will all depend on the clinical scenario when it's to be started, right? If the patient has got something like, say, viral-like illness, and if you are suspecting a bacterial illness in that, so you cannot ask for the sputum examination, sputum culture. You should not ask rather. So within 3 days, we know that the viral fever is going to be there for minimum 3 days and as maximum as for 7 days. So in this case, you are supposed to, on daily basis, you are supposed to monitor whether there is some clinical deterioration is there, new signs are appearing, new symptoms are appearing or not. Based on that, you are supposed to. Suppose the patient on day 1 only the patient is coming to with the expectoration that is greenish. Obviously, I am supposed to advise the gram stain in that on the same day only. I cannot prolong it on very next day or after 2 days. In fact, I am supposed to ask for the culture report. Send the sputum for the culture on the same day only. So it all based on the whatever clinical scene that is there.
Right, sir. Sir,
एक डिक्टम याच्यामध्ये जो टायमिंग विचारला होता ना केव्हा सॅम्पल घ्यायचं ते तर अँटीबायोटिक द्यायच्या आधी शक्यतो सॅम्पल घेतलं पाहिजे हा डिक्टम नंतर घ्यायचं नाही पेशंटला अँटीबायोटिक्स द्यायचे आहेत त्याच्या आधी सॅम्पल घ्या हा सगळ्यात महत्वाचा पॉइंट आहे
Right, sir. So this was the next question, sir, actually. So तुम्ही आधीच आन्सर दिलेलं. ठीक आहे. So any other questions? Sir, can microbial resistance affect vaccine efficacy?
झालं होतं ना ते सर, ते झालं ना. तुम्ही कोणचं वॅक्सिन देणार त्याच्यावरती डिपेंडेंट आहे सर ते.
Depends on that.
हा
Next question. कालच्या झालं already.
Use of antibiotics.
Sir, use of antibiotics affect the society as a whole in terms for the treatment. So इथे क्वेश्चन काय आहे ते त्यांनी डिफाईन नाही केले प्रॉपरली. काय यूज आहे असं त्यांचं म्हणणं आहे त्याच्यामध्ये की सोसायटीला काय यूज आहे अँटीबायोटिक्सचा, की ट्रीटमेंटसाठी आपण जे यूज करतो. पण तुम्ही जर अँटीबायोटिक रेजिस्टन्स म्हणताय तर मग यूज काय आहे?
नाही. अहो, तो जो उपयोग आहे अँटीबायोटिक्सचा तो वंडर ड्रग आहे. आज आपल्याला त्याचं महत्व कळत नाहीये, कारण की आधीच्या काळामध्ये साधं सोर थ्रोट झालं, काही स्किन इन्फेक्शन झालं तर लोक मरून जायचे. आणि अँटीबायोटिक्स आले म्हणून आज आपल्याला हे सगळं ट्रीटमेंट इझी वाटतं. सगळे सर्जरीज आपल्याला एवढ्या इझी वाटतात. ट्रान्सप्लांटेशन करतो, हार्ट ट्रान्सप्लांट करतो आपण, नवीन नवीन नीज पुटअप करतो आपण, काही पण करतोय आज आपण. म्हणजे इतकं फ्रीली आपण करू शकतो कारण की अँटीबायोटिक्स आहेत. जर का हे अँटीबायोटिक्स नसतील तर ह्या सगळ्या ब्रांचेस बंद होतील. हा सगळ्यात महत्वाचा पॉइंट आहे की जर का अँटीबायोटिक्स नसतील तर ह्या मोठ्या सर्जरीज करणं शक्य होणार नाही. त्यामुळे आपल्याला अँटीबायोटिक्स वाचवायचे आहेत. हे अतिशय प्रेशियस कमोडिटी आहे आणि ही आपल्याला आपण काळजी घेऊन वाचवायची आहे. हा सगळ्यात महत्वाचा संदेश आज आपल्याला द्यायची इच्छा आहे सगळ्यांना. कम्युनिटी करता अत्यंत महत्वाचे आहेत अँटीमायक्रोबियल्स. सगळं ठप होईल आपलं मेडिकल सायन्स.
तुम्हाला सांगतो, एड्सचे पेशंट असतात, HIV चे पेशंट असतात, त्यांना ऑपॉर्च्युनिटी इन्फेक्शन खूपच चान्सेस होऊन जातात. स्पेसिफिकली CD4 जर लेस दॅन 200 असलं, मग अशा लोकांना आपल्याला सेप्ट्रान, HIV हा असा ग्रुप आहे की त्यांना आपल्याला प्रोफिलॅक्टिक सेप्ट्रान देऊनच पुढचं कॉम्प्लिकेशन हे टाळता येऊ शकतं. नाहीतर काय होतं की एखाद्या वेळेस PJV किंवा न्यूमोसिस्टिस जिरोविसी इन्फेक्शन झालं, द पेशंट्स आर गोइंग टू डाय ऑफ दॅट थिंग. तुमच्या लक्षात आलं ना, कारण PCP कॅन मेक द पेशंट डाय. ते साध्या सेप्ट्रान प्रोफिलॅक्सिस देऊन, म्हणजे सेप्ट्रानचं एवढं महत्व आहे, म्हणजे सेप्ट्रानच जर नसता राहिला तर पेशंट रादर दॅन डाईंग ऑफ द HIV इन्फेक्शन पर से would have died because of the PCP.
Right, sir. Right. So
I would just like to add
yes,
the
ma'am.
concept of AWARE, which is propagated by WHO, that is access, watch, and reserve. Sir has already highlighted that antibiotics are wonder drugs. So we need to remember that because they would be needed, and there is a lot of controversy as to who would be the prescribing doctor. I mean, that's a different aspect, but probably at remote places where specialists may not be available. But the access group of antibiotics, if can be prescribed by the doctors at that point, it's going to save lives. On the other hand, use of these reserve drugs in hospitals without a proper management, I mean, not understanding the whole, indiscriminate use that is there, that can lead to hazardous effects. So there has to be a balance that needs to be generated for using these antibiotics, and there the role of the AWARE classification comes up, and we can have use that to guide.
Yes, thank you, ma'am. You're right. Ma'am, next question is त्यांचा की which section of the age group is most affected by antibiotic resistance? Any of you can answer.
तर सगळ्यात महत्वाचा पॉइंट मला एम्फसाइज करायचा आहे. बरं झाला प्रश्न आला. माणूस रेजिस्टंट होत नसतो, त्याच्यामधले बॅक्टेरिया रेजिस्टंट होत असतात. त्यामुळे लहान मूल असो, मोठं मूल असो, माणूस असो, कोणी असो, रेजिस्टंट ती व्यक्ती होणार नाहीये. रेजिस्टंट बॅक्टेरिया होणार आहेत त्याच्यामधले. आणि बॅक्टेरियाचं आणि ते तुम्हाला कुणाला इन्फेक्शन झालं याचं काही घेणं देणं नाहीये. बॅक्टेरियाचे रेजिस्टन्सचे जे त्यांचे मेकॅनिझम्स आहे, जेनेटिक मेकॅनिझम आहे, सरांनी आत्ताच सांगितलं ना आपल्याला की 1 मिलियन जर का मल्टिप्लिकेशन झाले तर एक म्युटेशन ऍड होऊनच जात असतो. त्यामुळे म्युटेशनचे रेट्स हे कॉन्स्टंट आहेत. म्युटेशन हे होतच राहणार आहे. आपण अँटीबायोटिक्स देऊन काय करतोय तर हे सगळे म्युटंट सिलेक्ट करत बसतोय. हे सगळे सिलेक्ट होत आहेत आणि मग शेवटी तेच उरत आहेत की जे म्युटंट्स आहेत आणि रेजिस्टंट आहेत. त्यामुळे रेझिस्टन्स हा बॅक्टेरियाशी निगडित शब्द आहे. एखादा व्यक्ती रेझिस्टंट होत नाही असा बरेचदा शब्द असे वापरले जातात. अरे खूप अँटीबायोटिक्स तू घेऊ नको, नाही तर तू अँटीबायोटिक्सला रेझिस्टंट होशील. माणूस नाही होत रेझिस्टंट. ठीक आहे, आता त्याच्यामध्ये प्रॉब्लेम कसा होईल, तुम्ही जेव्हा खूप अँटीबायोटिक्स घ्याल तेव्हा तुमच्या गटमध्ये जेवढे बॅक्टेरिया आहेत ते सगळे रेझिस्टंटच राहतील, कारण तुम्ही सिलेक्ट आउट करून टाकलेलं आहे. आणि मग जर का त्या गटच्या बॅक्टेरियमनी तुम्हाला युरिनरी ट्रॅक्ट इन्फेक्शन झालं तर ते युरिनरी ट्रॅक्ट इन्फेक्शन ट्रीट करता येणार नाहीये. किंवा जर का तुमच्या गटमधले तुम्हीच तुमचे बॅक्टेरिया सगळे रेझिस्टंट करून ठेवले आणि मग हे जेव्हा दुसऱ्या ऑर्गन मध्ये जातील, गटमधला बॅक्टेरिया जेव्हा ब्लड मध्ये जाईल सेप्टिसिमा करायला, तेव्हा तो आधीपासूनच ड्रग रेझिस्टंट राहणार आहे. म्हणजे बॅक्टेरिया ड्रग रेझिस्टंट राहणार आहेत तुमच्या या कृतीमुळे. माणूस ड्रग रेझिस्टंट नाही होत. ठीक आहे, आय थिंक दॅट कन्फ्युजन इफ देयर वॉज देयर, आय वॉन्टेड टू रिमूव्ह दॅट कन्फ्युजन.
Right, sir. It was a good question. Thank you. सर मॅडम नेक्स्ट क्वेश्चन असं आहे की कार्यकर्ते सर किंवा बजाज मॅडम कॅन आन्सर ऑन दिस प्रॉब्ली. कॅन यू थ्रो लाईट ऑन हाऊ टू इंटरप्रेट कल्चर सेन्सिटिव्हिटी रिपोर्ट?
उत्तर दे बाबा तू.
Actually, yeah. Actually, culture sensitivity reports, that is why I projected a report form also for you to see. Again, these are of two types. One would be when you do a manual culture sensitivity, or you are doing an automated culture drug sensitivity. So the pattern is very clear. The name of the organism is given, and then the drugs which are supposed to be working for that particular pathogen, only those should ideally be applied. So sometimes in many laboratories, you will have the whole panel. For example, you will have a cephalosporin, maybe first or second generation cephalosporin for staphylococci, which are not going to be effective. So that is one thing which is important. So usually when there is a microbiologist, he will not apply there. And then it is written there, sensitive, intermediate, and resistant, which is the most common pattern which is to be employed. Sensitive means the given antibiotic in the standard dose the patient should respond. Okay. Intermediate, then resistant is when the zone diameter is less, or that means when you give that particular drug, technically there should not be response. So that means the particular bacterium is resistant to that antibiotic. When it is intermediate, then it means that you could try higher doses, and especially if the infection is the site where the drug is being excreted, there this particular antibiotic can be given. So these are the three standard methodologies of interpretation. Now, here we have to understand some limitations, that sometimes you would have an intermediate or a resistant report, but in vivo the patient is responding. Okay, so then there is no need to change the drug. Even if it is showing resistance, you can still continue with that. If there is a sensitive report, you can be sure that there's going to be a response. And there is a fourth kind of interpretation, which is called as the susceptibility dose dependent, that is called as SDD. So this is very off late, like from the past 4 years, this particular interpretation has come up for certain cephalosporins like the cefepime. So here it means that you can try giving that particular drug to its maximum dose. Okay, and the patient should respond, and the side effects also should be like tolerable. So that is the interpretation you have for SDD. So only labs which are really to that level of reporting this SDD pattern is communicated, and we mainly also use it for fungi, for antifungal susceptibility testing. SDD approach is used. And the other thing which can be there on the report, which should be there ideally, is a comment. You want to, as simple as if it's an MRSA and the microbiologist wants to convey that do not give any beta-lactam antibiotics to this particular patient. So that's all you interpret. If that is what I mean, the question is. If anything more needed, I would intervene.
तर तुम्हाला काही सांगायचं आणखी त्याच्यावरती?
नाही सर, तिने कव्हर केलंय सगळं जवळपास.
नेक्स्ट क्वेश्चन आहे सर की वाय MDR इज डिफरंट फॉर डिफरंट पेशंट अँड डिफरंट बॅक्टेरिया? बोर्डसे सर.
What is the question
It's
actually?
susceptibility. It should be genetic susceptibility.
मॅम मी परत एकदा रिपीट करतो क्वेश्चन. Why MDR is different for different patient and different bacteria? सरांचं म्हणणं आहे की ससेप्टिबिलिटी मुळे इट मे बी डिफरंट फॉर द डिफरंट पेशंट्स. दॅट इज ट्रू. Next question. How to choose the infusion fluid, NS or RL, for a particular antibiotic?
Yes.
I think the standard protocols are there. It is already given in the textbook that which fluid is to be used in the normal saline, which fluid is to be used in the Ringer's lactate or in the DNS. Perhaps normal saline is the best vehicle for giving the antibiotics in a patient rather than say DNS or D5 or D10.
सर खलाटे सरांचा एक क्वेश्चन आहे. कल्चर रिपोर्ट्स showing millimeters, what does it indicate?
Yes, I intentionally did not want to mention this because many times the clinicians get confused about this. These millimeters are the zone diameters for that. See, the process which is done is it's called as a disk diffusion methodology. We incorporate antibiotic in the on the disc, which is made up of filter paper, and that diffuses into the medium. And there is a bacterial growth. So what we actually read is a zone of inhibition by the bacteria. That means the drug has inhibited the drug is inhibited that particular bacterium, and we measure the zone diameter. Okay. Now this particular component, that when we do the interpretation, we add the zone diameter, that is more for a microbiological perspective. So sometimes these lab reports also mention this. So the criteria for sensitive, intermediate, resistant is based upon the size of this particular zone. Okay, so for example, zone size above 27 millimeters is sensitive, right? So therefore that particular size will be written there. So the confusion which the clinicians get into is sometimes there is something showing 27, the other is showing 29 or 30. So they feel the more the diameter of this particular antibiotic is, it will be more sensitive. It is not like that. Every drug will have a different zone of diameter for a different bacteria. Okay, so this drug bug combination which is there, the disk diffusion diameters are defined, and this whole process is followed by microbiologists using the CLSI guidelines, which I mentioned during my presentation.
तर वेगळ्या शब्दामध्ये
Standard
सांगतो मी
guidelines.
तुम्हाला.
Yes.
ज्योती, I would convey it in different
Yes.
language.
Yes.
सर कसं आहे, हे जे डिफ्युजन आमच्या इकडचे जे पेट्री डिश मध्ये होत असतं ना, ते त्या साईज ऑफ अँटीमायक्रोबियल वरती डिपेंडेंट असतं. जर का एक अँटीमायक्रोबियलचा साईज कमी आहे, छोटा आहे, तर तो जास्त डिफ्यूज होतो. जो खूप हेवी आहे, फॉर एक्झाम्पल कोलिस्टिन सारखे, ते तर डिफ्यूजच होत नाहीत. त्याचे साईजेस जे ते अत्यंत छोटे असतात. आता मोठा साईज हा त्या अँटीबायोटिकचं कॅरेक्टरिस्टिक आहे, कारण की त्याचं मॉलिक्युलर साईज कमी आहे. मग त्याच्याकरता सेन्सिटिव्हचा झोन हा मोठाच असणार आहे, रेझिस्टंटचा झोन सुद्धा मोठाच असणार आहे. पण त्याचा जो आहे तो एक तुम्हाला दिलेला असणार की 27 ते 29 पर्यंत जर का गेला किंवा 27 मिलीमीटर पेक्षा जास्त असेल तर सेन्सिटिव्ह, 15 पेक्षा कमी असेल तर रेझिस्टंट. दुसरा एखादा खूपच हेवी मॉलिक्यूल आहे, जाड मोठा मॉलिक्यूल आहे, तो जास्त डिफ्यूजच होणार नाही. तर समजा 10च्या वर असेल तर सेन्सिटिव्ह, 5च्या खाली असेल तर रेझिस्टंट, कारण की ती जी डिस्क आहे तिचं डायमीटर 4 मिलीमीटर असतं. तर मग अशा किंवा 5 मिलीमीटर असतं. मग अशा परिस्थितीमध्ये तो जो आहे अँटीमायक्रोबियल तो त्याच्या साईज वरनं झोन साईज घेणार आहे. त्यामुळे जर का तुम्ही आता 10 अँटीमायक्रोबियल्स बघितले आणि त्याच्यामधला एखाद्याला जर का झोन साईज खूपच जास्त आहे तर तो खूपच जास्त इफेक्टिव्ह आहे असा अर्थ काढणं योग्य नव्हे. ते अँटीमायक्रोबियल प्रमाणे तो साईज डिफर होतो, त्याच्या कॅरेक्टरिस्टिक प्रमाणे तो डिफर होतो, फिजिकल कॅरेक्टरिस्टिक, केमिकल कॅरेक्टरिस्टिक्स प्रमाणे तो झोन साईज डिटरमाइन होतो. आणि त्या झोन साईजचं इंटरप्रिटेशन हे मायक्रोबायोलॉजिस्टनी करायचं असतं की तो सेन्सिटिव्ह आहे अथवा इंटरमिजिएट आहे का रेझिस्टंट आहे. आपल्याला जे ऍज अ क्लिनिशियन बघायचं आहे ते whether it is sensitive, intermediate, or resistance. The zone size is nothing to do with how powerful that antimicrobial is. चालेल sir. Thank you.
Nice question and nice answer for both of you. Sir, अजून एक क्वेश्चन आहे, इंटरेस्टिंग क्वेश्चन आहे. Does the poultry infused with antibiotics is a cause for antibiotic resistance for non-vegetarians?
आपण काही ऐका ऐका, ही जी पोल्ट्री आहे जिला अँटीबायोटिक दिलंय, ती अँटीबायोटिक सहित आपण खातोय म्हणून रेझिस्टन्स वाढतोय असं नाहीये. त्या कोंबडीच्या गट मध्ये जे बॅक्टेरिया आहेत ते रेझिस्टंट होत आहेत. सरांनी नाही सांगितलं का सिलेक्शन, तर तो त्याच्या गट मधले जे सेन्सिटिव्ह बॅक्टेरिया आहेत ते मारले जात आहेत आणि फक्त रेझिस्टंट बॅक्टेरिया उरत आहेत. हे सगळ्या जगाला कंटॅमिनेट करत सुटलेले आहेत, एन्व्हायरमेंटला कंटॅमिनेट करतायत. जर का ते नीट धुतलं नाही चिकन तुम्ही तर ते होणार आहे. कारण की आता हे चिकन तर तुम्ही उकळू म्हणजे त्याला खाणार जेव्हा आहात तेव्हा बॉईलच करणार आहात ना सगळं. त्यामुळे असं नसतं होते. ते जे इन्फेक्शनचं जे आपण बोलतो आहोत ते त्या चिकन मधनं येणाऱ्या अँटीबायोटिक्स खाल्ल्यामुळे आहे नाहीये, तसं नाहीये. त्याच्या गटमध्ये जे बॅक्टेरिया आहेत ते रेझिस्टंट होत जात आहेत आणि ते रेझिस्टंट बॅक्टेरिया परिसरामध्ये सगळे पसरतायत. हा त्याच्या मागचा कन्सेप्ट आहे.
लोकांनी नॉन व्हेजिटेरियन खाऊ नये हा साधा त्याच्या रूप आहे.
थँक्यू सर. सर, एक लास्ट क्वेश्चन आहे माझ्याकडून की एक कन्सेप्ट मध्ये आली होती TDR, टोटल ड्रग रेजिस्टन्स. तर ती काय कन्सेप्ट आहे तुम्ही समजून सांगू शकता का थोडंसं शॉर्ट मध्ये?
सर पॅनडीआर किंवा एक्सडीआर किंवा TDR ज्याला म्हणतो, एक्सडीआर आणि पॅनडीआर. पॅनडीआर म्हणजे ऑल अँटीबायोटिक्स, द मायक्रोब इज रेजिस्टंट टू ऑल दी अँटीबायोटिक्स ऑलमोस्ट. मिनिमम 7 अँटीबायोटिक्सला तरी तो रेजिस्टंट आहे असा त्याचा अर्थ होतो पॅनडीआर म्हणजे. एक्सडीआर म्हणजे ऍटलिस्ट 1 ते 2 असा यांना तरी तो ससेप्टेबल आहे, बाकीच्यांना रेजिस्टंट आहे असा त्याचा.
व्हॅन्कोमायसिन नाही राहिलं आणि कोलिस्टिन नाही राहिलं तर सर ते झालं ऑल सगळ्यालाच रेजिस्टंट झालं. कोणीच काहीच उपयोग होणार नाही, कशाचाच नाही होणार.
Right. So questions are ended, sir. So again, I thank you to all, to Bajaj Madam, Karyakarte sir, Borse sir, for these wonderful sessions, as well as like Borse sir has taken case presentations also. Like छोट्याशा केस स्टडी प्रेझेंट केल्या मध्ये छान वाटलं आणि कार्यकर्ते सरांनी जिनॉमिक सिक्वेन्सचं महत्व त्यांनी समजून सांगितलं. कल्चर सेन्सिटिव्हिटीचं मॅडमनी समजून सांगितलं की कसं त्याला आपण ऍक्ट करायचं आणि त्याच्यासाठी काय काय प्रिव्हेन्शन करणं एक्सपेक्टेड आहे. जे AMR चा प्लॅन कसा आखला पाहिजे किंवा काय केलं पाहिजे पुढे, त्याच्यासाठी त्यांनी फार छान डिस्क्रिप्शन सांगितलं. सो आय अगेन थँक यू टू ऑल ऑफ यू. आणि मेडिकल ऑफिसर्सने ही विनंती आहे की तुम्ही त्याच्यावरती अजून चांगला अभ्यास करा आणि ट्राय टू बी परफेक्ट इन युअर क्लिनिकल नॉलेज अँड सर्व्हिस. Thanks to all of you again.
Thank you, sir.
Thank you all.
Thank you, sir.
Thank you, sir. Thank you.
Thank you, madam. Oh, sorry. बंद करा बंद.
एक